Hello, welcome. My name is Patrick Hwu. I'm president of SITC and also president and CEO of the Moffitt Cancer Center in Tampa, Florida. I am extremely delighted today to have Dr. Liz Jaffee here for our Fireside Chat. Dr. Jaffee is currently the Deputy Director of the Cancer Center at the Johns Hopkins Hospital and has many awards and honors to her name. She has been in the field of tumor immunology and really pioneered many treatments, especially in GI malignancies. She's been past president of AACR, elected to the National Academy of Medicine, had received the CRI Coley Award, the AACR Burchenal Award, amongst many awards. She is chair of the National Cancer Advisory Board. And above all that, she is just extremely kind and compassionate physician and a mentor who now has trainees that are leaders throughout the country and the world in tumor immunology. So just one of my favorite people in the world. So thank you, Liz, for taking the time to be here today.
Thank you, Patrick. That was such a nice introduction, and you're one of my favorite people as well. So, as you know.
Wonderful. So, you've really been a pioneer in tumor immunology. I mean, starting in the days when no one believed that the immune system was important for cancer. And not only that, you went into maybe the toughest cancer to try to treat with tumor immunology, pancreatic cancer. And yet you've made so much, you practically invented the field of pancreatic cancer tumor immunology. I mean, you really were the first, and you've made the most substantial progress in there. So tell us, what were you thinking in going into this, and what stimulated you to be a pancreatic cancer tumor immunologist?
Well, it's a good question, and the easy answer is that, I've always wanted to do something about cancer since I was young and had an uncle who died of it. I think we all are, often touched by some personal experience. And he died of lung cancer, of course, way back in the 70s. And, we used to go to, believe it or not, the American Cancer Society meetings. I'd go with my grandmother. And then when I was in college, I got really excited because at the time I was in college, we were learning a lot about virology and the immune system. And I thought, wow, that's when I realized, it hit me, that if the immune system can recognize differences in a virally infected cell, then why can't the immune system also pick up changes in a cancer cell? And so I got really excited about that as a college student. Did some research in college, did some research during residency, once some of the technologies had improved. And I never went back. I always thought that this was the way to go for me, for my career. Originally, I was going to apply this work to kidney cancer, and I had started doing that. And then my uncle died of pancreatic cancer. And at the same time, I was at an institution where they saw a lot of pancreatic cancer, and the chief surgeon who did much of the surgery said to me, why can't you apply this to pancreatic cancer? We need to do something more. Surgery is done. It's done the best it can do. And I think it was all of these different opportunities. And what I learned is that, you want to be open to new opportunities and new pathways. And that's how I got led down this road.
Wow, and it's been so successful and impactful. Where do you see that the field going in terms of, we've had some breakthroughs in melanoma and lymphoma with CAR T and other areas of more immunogenic cancers. What do we need to do in the area of pancreatic cancer and other GI malignancies?
I think that's a critical question. And, thank goodness, as you know, there's so many wonderful young people now, as well as more experienced people in our community who are really trying to tackle this problem together. And I think that's important because it's bringing together many experts. And with the new technologies that are available, single cell analysis, multiplexing, we can really start to understand the very complex signals within the tumor microenvironment. And it's really about trying to understand how the tumors are communicating to not only the inflammatory cells that come in to try to prevent activation of a good T cell or a B cell, but importantly, importantly, it's also that stromal component. I think of the stroma as a real big barrier right now. And we used to think of the stroma as something that's just kind of an inert process, but it's really a dynamic process. And we need to better understand the multiple cellular types and multiple signaling between stromal cells, the tumor, and also the inflammatory cells such as monocytes and even T cells and B cells, to be able to really understand how to make a big difference. We know that these cancers, these GI cancers, they usually do not induce a good T cell because they don't have a high mutational rate. They have these stromal barriers that may not be as strong in cancers like melanoma or even lung cancer. So it's clear that there are big differences, but they're not differences that can't be overcome. And I think we're making progress. We're starting to see in a number of different clinical trials that have been published as well as that are ongoing that we can actually make a difference in these patients. So it's just a matter of understanding the entire complex signaling pathways and being able to now intervene in those pathways.
Great, because the microenvironment seems to be even greater challenge with pancreatic cancer than many other cancers, is what you're saying. The other challenge potentially are antigens and how many antigens there are available, how strong the antigens are. And you've done a lot of great work trying to identify different antigens, and not only pancreatic cancer, but a number of classic mouse models as well. You've really figured out what the antigens are that the T cells recognize. So what do you think about the best antigens to target in pancreatic cancer?
Yeah, that's a really important question. I think we're still trying to figure that out. Certainly, there are many neoantigens in the cancers that respond to single agent immune checkpoint antibodies, but we still haven't proven that it's the neoantigens that are most important, right? Or at least the somatic mutations that are the typical ones we test for. And in fact, in renal cell, there's been such beautiful work showing that indels are more immunogenic than even these somatic variant type neoantigens. Certainly oncogenes can be immunogenic. We see T cell responses to oncogenes, and some of these cancers, pancreatic cancer being an example, is very oncogene driven. And so it may not be a neoantigen in the classic sense, but an oncogene that we need to target. So we still don't know what the best antigens are, because we really need to be able not only to prove that you can measure a T cell, but that the T cell is getting into the cancer and killing the cancer. So I think this is an area that we really need to study in more detail, and we're trying to do this, looking at different types of antigen responses and what gets into the tumor.
Yeah, you've taken a number of really innovative approaches towards attacking pancreatic cancer, many different platforms, including vaccines, where you're really a pioneer of vaccines in GI malignancies. What do you think about the role of vaccines for the future of immunotherapy, especially in GI malignancies? We're so excited that the COVID vaccine came from cancer vaccines. Do you think, I know you've tried different models like listeria and other models, if I remember right, and then what do you think about the RNA-based vaccines, and do they play a role in pancreatic cancer immunotherapy?
That is a really great question. And I think, the RNA vaccines for COVID are really going to help us move faster in cancer. We were testing the RNA vaccines in our preclinical models, working with Moderna prior to the pandemic. And we did see that these mRNA vaccines, when you compare them to listeria or you compare them to long peptides, which can be often very effective at inducing a T cell response, that the mRNA vaccines actually are in some ways more potent. They have the ability to expand the number of epitopes that are being recognized by T cells in comparison to some of these other mechanisms. Listeria is a nice one too. I mean, listeria mRNAs, what they're doing, what makes them so successful in their ability to induce a good T cell response is that they also provide an innate stimulus, right? So mRNAs provide innate through TLRs, listeria, not only through TLRs, but through the STING pathway. So they're a way of naturally providing an adjuvant in addition to the antigens that are being targeted. So I think mRNA is the way to go. They're safer than a bacteria or a virus. I'm hoping we could do more with this. The problem up until recently was that the technology was quite expensive. So to get to a patient, we were being told it could take as much as $500,000 per patient. That's like at the level of CAR T cell therapy. And as we all know, that's a very difficult barrier, financial barrier to meet in clinical trials. So I'm hoping that with what's happened with developing these for COVID and with the more recent developments in mRNA technology, that it will become something we can more easily test in patients with cancer.
And do you foresee that we will take a patient's individual cancer and personalize that vaccine? Or do you think we're going to be able to have some off-the-shelf vaccines that we can use on multiple patients?
Yeah, that's a great question. I think it's going to be a combination. I think that we will need to look and see what an individual patient's cancer is expressing. But I think we also hopefully will be able to have off-the-shelf oncogene and even sometimes some overexpressed antigens that are quite immunogenic. In pancreatic cancer, we do know that there are a couple, such as mesothelin, is quite immunogenic. And it's not expressed by many normal cells. So we don't fear autoimmunity by targeting that antigen, even though it's not a mutated antigen, it's just dysregulated. And we know in melanoma too, there are a number, as you know better than me, there are a number of antigens that are more tissue specific, but they're quite immunogenic. So I think this is an area that we really need to pursue and better understand. And I suspect it's going to be a combination.
I remember you were the main driver to set up the cell therapy facility at Johns Hopkins originally. So what role do you see as cell therapy playing with pancreatic cancer and other GI malignancies?
Yeah, I mean, I'm very hopeful that cell therapy could play a role as well. And I'm part of a Stand Up to Cancer grant with Phil Greenberg, who's trying to develop a T-cell adoptive transfer approach targeting mesothelin initially, but then potentially targeting some neoantigens as well. And but I think that with cancers like pancreatic cancer, it's still, you have to do something about that stroma to get it in, to get the T cell into the tumor. So I think that's still the challenge in these really tough solid tumors that have such a big stromal barrier. But I think it's going to be doable. And we've seen with vaccines, even when we test our vaccines in the neoadjuvant setting, we find that even with just a vaccine, we can actually bypass that barrier and get these lymphoid aggregates infiltrating the tumor. So I think it's a matter of just altering some signaling during the process of the therapy within the stroma to be able to gain better access.
You mentioned before also the cost of care, and we know that cancer drugs can be awfully expensive. And you mentioned CAR T, for example, which is expensive, and certain vaccines can be expensive, and other drugs. What's your thoughts about the scalability of cancer treatments? I know at Johns Hopkins, part of your mission of the hospital and how it was set up was to treat everybody that came in, and I really respect that mission of Johns Hopkins. What's your thought about the scalability, and how are we going to implement the cutting edge cancer care therapies to all populations?
Yeah, I think that really is the big question in cancer care, implementation of good therapies to all patients. And, I think this is going to be beyond just academic oncologists such as you and I. We really need the help of, Congress, of healthcare, financial delivery groups. It's really a challenge. And, I think the Affordable Care Act has made it a bit easier. I always tell people, who are afraid of, they call it socialized medicine, government paying for healthcare. I try to explain to them, in cancer care, experimental therapy, the best insurance to have is Medicare. They say yes to even phase 1 therapy right away. My patients never have to be delayed in getting their therapy. Every other type of healthcare insurance, you have to go through a lot of paperwork, a lot of loops to get approval. So I really think our healthcare system needs to do a better job of providing good healthcare to everyone, because with these bad diseases, it's just not fair that people should, have to avoid getting a potentially curative or treatable, treatment that treats their disease and gives them good quality of life. Getting out to the public as well is very important. So that's almost a separate issue, and that's having the ability to do more remote type access. And I think that's where you're headed. I think COVID has taught us that we can treat patients remotely. And we're even doing a clinical trial now where we're giving experimental therapy in the home, which may sound like it's easy to do, but it's really not, because you have to have your research nurses train the home care nurses. The research nurses aren't the ones, in the hospital leaving to go to the home. But it's doable, and it's safe. And with good communication between the physician and the nurses and the patient, we're able to safely give even a early phase therapy to patients who may not be able to get into the hospital quickly. So I think, we're starting to think about these new ways of trying to bring our really exciting treatments that have good potential to patients who normally wouldn't have easy access.
It's very impactful. Boy, if you can pilot and figure out how to do clinical trials more in the home remotely, that would be very impactful. Being able to get trials to many different populations who can't really afford to travel into a big center like Johns Hopkins. In your role as chair of the National Cancer Advisory Board, as well as now the National Academy of Medicine, are these issues coming up more and more about scalability, implementation, and getting therapies out to disparate populations?
Yes, in fact, I think when I was one of the co-chairs of the Blue Ribbon panel, we had to come up with priorities for the National Cancer Institute. So that was, about almost 5 years ago now. And the priorities that we came up with for utilizing the moonshot funding included implementation science, and that was a very high priority. And every priority included getting to underrepresented minorities and populations that don't have easy access to healthcare. So I think this is a very important area. I think, the National Cancer Institute does realize that. And yes, the National Academy of Medicine also has, looked at this in different ways as well. And typically what happens is, I think Congress will, or the White House will, ask the national academies to do some research and come out with a position paper that helps the greater community to make some changes. So hopefully all of this will continue. I think it needs to be a continuation. We need to be able to measure the changes and what has worked, what hasn't, and keep doing a better job. But it's going to take bringing together, many groups. I mean, we all have to work together. Again, the insurance companies have to work with us, allow better access to these experimental therapies to patient populations that normally don't have it. I think pharmaceutical companies have to help us with the cost. I mean, the cost of doing these therapies is still extremely expensive. And then, of course, the government has to help us with providing better ways to deliver healthcare within all the rules that we have to deal with.
Thank you. It's really such an important area. Another important area that you've been instrumental in is mentoring women in cancer research. A lot of people are now leaders that you've mentored. You've been very active in the Women in Cancer Immunotherapy Network, or WIN, program of SITC, and we really appreciate that. What do you feel is needed right now to try to enhance women in research and in leadership positions?
Yeah, it's a great question. So, first of all, when I talk about women, I've started to also try to make sure that people understand that there's another group that also we have to think about, and that's the underrepresented minorities. And I think in some ways they've been more neglected in recent times than women, although women certainly have had their challenges and continue to have their challenges. So I hope that any changes that we're all making would be for all of these groups that are at risk for leaving our field, or are at risk for not joining our field, the younger generation, which is what you and I are both concerned about. We want to bring in the next generation to make sure that innovation and new medical therapies are advanced. So I think women are doing better. I think it's still, COVID has, obviously thrown a wrench into some of the progress we've made, because even though both men and women have taken on more, women for sure have taken on even more for their children at home or for parents who are ill. I hear this all the time. And we've, what I've done at locally as well as nationally is try to come up with what I call COVID recovery type plans. And so as part of our institution, I pushed forward not only childcare mechanisms to make sure that people had the funding to pay for childcare, keeping childcare open at the local level during COVID, those sorts of things, but also to provide funding, bridge funding mechanisms for our particularly early career women faculty who are at risk, and also men, underrepresented minorities, but women in particular were more at risk because they unfortunately also had more of the responsibility at home. So those are some of the things we've done at the level of the National Cancer Advisory Board. One of the things I did early on was bring this up to the leadership at the NCI. And I don't know how many people are aware, but there's this mechanism R37. So when you get your first R01, it automatically becomes a 7-year grant. And that was with the concept of women in particular who are childbearing, taking care of kids at home, and 5 years is just not enough to get a lot of work done and also recompete an R01. So I think, these may seem small, but I think what some of these things do is it makes the leaders aware that these are issues and that we could do a better job of keeping our early career faculty or attracting new faculty and new fellows into our fields. So I'm hopeful that that is the case. As far as the glass ceiling, it's a complex question because there is a glass ceiling still in leadership, and I see it at my own institution. I see it at other institutions. And, women have to support women. Women have to make sure that if they're sitting on a board and they're the only woman, that this is recognized. For a while, I was the only woman on our executive oncology committee board, which is where all the decisions are made. And there was no underrepresented minority when I first started. There's now 4 women and additionally two underrepresented minorities on that board. And wow, it's made a big difference. It's made a big difference in everything we do. So I think as a woman, rather than saying, oh, I'm lucky to be here, you have to push forward and make sure that you keep, in a very professional way, reminding the leaders that this is not acceptable, that we need more diversity on this board. So same thing with, being on the podium at different meetings. What I find, and I don't know if you found this, Patrick, but when you sit on a committee to organize a conference, often people think about their friends. And in the old days, it was all white men who thought about all their friends who were white men. I don't think they were purposely avoiding, bringing diversity into it, but they weren't thinking about it. And so I think as women, as underrepresented minorities, we have to provide suggestions of some great people who could also be joining the podium and presenting. And so, I made a big difference, I think, at ACR as president that year, because I think for the first time we had 38% women who presented, and we had, I believe it was almost 30% underrepresented minorities presenting, first time ever. And my answer to that, because people noticed it, was that the next president has to do even better. Okay, this wasn't a one-time deal. So I think, it's an active process and we have to keep doing it. It's complex, and I'm sorry I'm going on, but obviously I'm very passionate about this. I think leadership is hard. So, a lot of women look to me and say, how come you're not cancer center director? How come you're not leading this or that? And I have to be honest that I never wanted to be a cancer center director. I'm very happy that people want to. But, as a woman and as a leader, I decided for myself that I love the science and the mentoring. And so I'm leading at national levels, doing things like at AACR or at the National Cancer Advisory Board. But maybe in some ways, when women come through at Hopkins, they don't see me in necessarily the highest leadership position and they wonder why. But it's also an active choice that I've made. And, I don't think you have to take on a title. You could still lead, is what I'm trying to say. You could still be a leader without taking on a title such as chairman or, cancer center director. But you do have to push for diversity when you sit on recruitment committees. So you have to make sure that there's a good, diverse group of people that are being considered.
Great. You've been so impactful in your leadership positions. As I remember when you were president of AACR and the focus you had, and when you've been involved in SITC's programming, the focus you've had on making sure the playing field was even for the presenters that we had. It was very impactful, your influence. And so, and what you're saying is a lot of these biases are unconscious. That's why they call it unconscious bias, but we have to be aware of it and then very intentional in making sure we correct these biases and even the playing field for leadership positions as well as speakers. I think it's really a wonderful point. You've been very influential by example, and you have so many leaders now that you've mentored personally out in the field. You must be very proud of them. What do you feel, what recommendations do you have for people that are mentoring others, and as well as young people that are coming up through the field?
Right. So when you're mentoring others, I think you don't want to shape someone into who you are. You want to figure out what are the needs of that individual, who do they want to be. You want to get to know them well enough that you can help them become who they want to be. And I think that's most important because we all have our strengths and weaknesses. We all have our passions, and everyone's different. And that's what's wonderful. We're all different. But I embrace those differences and try to promote that person through those differences in their career. And I have to tell you, it's like, I hate to make it this simple, but it's like having your own children and being so proud of them, like letting them be independent, but, facilitating enough that they can reach their goals. And when they do, for me, I'm more proud that they reach their goals. I'm happier than I was even for myself reaching my goals. And I just hope that other mentors can realize that really that's what makes life worth living, seeing people do well, seeing people you've had a positive effect on. For people coming up, what I tell people when they're looking at jobs for the first time, it's very important to make sure you identify a team of champions for yourself. And different people, different mentors can provide different things. So one mentor can't be everything to a person, right? It's better to have multiple mentors in the field. And even, at our stage, you and I mentor each other, right? We call each other when we need things, when we need to bounce things off. I mean, we always need to have those people we trust, who we know care about us, right? Who we know are going to give us good advice. And so I think the most important thing for people coming up is to make sure wherever they take a job that they have at least one or two champions there, and then they identify people nationally who can also be their champions. And I think if you have that, if you have people who are honest with you, who provide you with good feedback, and again, not just all positive, but constructive feedback, and you're able to take that constructive feedback in a good way, I think that's what you need. That's what you need when you're starting out. That's what you need when we're at our level, right? We still want constructive feedback. So that would be my most important thoughts on your question.
Great advice. And I do appreciate all those phone calls before I made the jump to Moffitt a few months ago. You've been really instrumental with SITC. You've been on the board of directors. You've been a leader. You were a keynote speaker last year at our meeting. And you also, as both a SITC member and AACR past president, you helped to lead our Science of Toxicities workshop, which was very successful, and it was extremely interesting. And it's coming out with a manuscript as well from that workshop. Can you talk about that a little bit?
Yeah, so, unfortunately, believe it or not, we had that, as you know, you were there, that symposium or that workshop right when we were shutting down the United States because of the pandemic. It was just turned into a pandemic. So we were on our last day when we were all getting phone calls, which was a shame because I think it slowed our progress in getting this manuscript out. But the workshop was very timely, and I believe it identified a number of areas that our community will want to hear about, and also hopefully funding mechanisms will want to support so that we can make progress. And so, as everyone hopefully knows, autoimmunity is a major side effects of our current immunotherapies, but they are manageable, but we don't really understand them mechanistically. And so we manage them with more non-specific therapies right now, such as steroids to inhibit an immune response acutely that may be autoimmune. But what we're hoping is to learn more about the mechanisms so that we could avoid those toxicities or very quickly just intercept specific toxicities so that we can continue the immunotherapies in patients who are benefiting. And so some of the areas we realized are very important are, one, we don't really have good models to study, these mechanisms of autoimmunity. And so we're really pushing for more funding and more interest in developing better models so we could really better understand these mechanisms. And then the second area that I think is high priority is to have a national biobank system, because again, this is not a common problem. It's more of an uncommon or sometimes rare. It's a condition because if you look at the different organs that are affected, it becomes a rare condition, not a very common condition. And so we really need the whole community, extramural, intramural, pharmaceutical groups to come together and really pool biospecimens and work together to better understand in patients what these autoimmune mechanisms are and how to intervene. So those are the two major areas that are coming out of our paper, our paper that will hopefully generate some further discussion. And SITC is just wonderful because it's really the only organization that focuses on cancer immunotherapy, right? And you and I have been a part of it since probably the beginning, and it really brought our community together from the beginning. And it stuck with us during a time when many of the agencies that fund or that have symposia didn't think immunotherapy was ever going to work for cancer. So, we were sort of out there for a while, siloed, but SITC kept us all coming together and thinking about the problems and really supporting all of us and bringing new people into the field to get us to where we are today. And it's never been a more exciting time. And now SITC is taking on the problems that we need to address to make immunotherapy even better. So it's really been the engine behind, what we do, in a sense, the engine in convening people, convening experts, convening pharmaceutical companies and government and academia, convening to discuss the current issues and to come up with ways to problem solve.
Well, you've been such an important and influential member of SITC. And I do remember that was one of the last conferences, the one you led, that I went to live before no more conferences. And then COVID hit. And, what's interesting is the bookend is that the SITC meeting in this November will be one of the first large live conferences after COVID. So we're real excited about that. Are you planning to come?
Absolutely. And I helped to develop one of the sessions, and I'm looking forward to the whole meeting. it's going to be so refreshing to just be able to see people in person, talk about science, meet the young people who are coming. In fact, I've been talking to a number of young faculty and fellows who I met at this Irving Symposium for Immunotherapy, which was a symposium that came out of Harvard, where they basically invited young scientists in immunotherapy from across the country to come to a couple of days symposium where they met some of the experts in the field, and we talked about just careers and how to promote yourself, those sorts of things. And now the follow-up has been meeting with these people one-on-one, and this week I've been talking to a number of them, and I kept saying, are you going to SITC? And they're all so excited that they're going to be able to go to an in-person meeting, meet all the people they saw at the Irving Symposium. So I think this is going to be so terrific. It's going to be terrific to see everybody.
That's wonderful. We're really looking forward to seeing you there. And we learned a lot from COVID. I mean, I never knew that we could do so much over Zoom or online. And so what do you think the future is going to look like in terms of, like we've been all over the world together. I remember we were in China together at an ACR meeting you invited me to, and other meetings like that. So what's the future going to look like, and how much live, how much Zoom, how much hybrid? What do you think we're going to do in terms of, as a science community, taking our learnings from COVID going forward?
Yeah, I truly think there's going to be a hybrid approach. I think there's nothing like having, an in-face meeting for SITC, let's say, or ACR, ASCO. Those are very important meetings where you have a lot of, side discussions in addition to the actual in-person conferences. But there's a lot of people who can't afford to come to it all around the world. And so it would be nice to be able to also have an option to be able to take part in these meetings through Zoom. And then, as you know, we do a number of these one-day travel to Asia or travel to Europe, for a one-day meeting. And that's a lot of time out of our day, out of our week. And so I think those sorts of meetings, board meetings, can be done, virtually. I don't think there's any problem because you could easily exchange data in smaller groups. So I think we really have to think about this, and, with each different situation, consider, what are the options. And I know that, still being part of the leadership at ACR, they're thinking about what should be hybrid, because, we do want to be able to reach people in Africa, people in Asia. It's often the young faculty and trainees who have the hardest time traveling. So if we really want to be able to encourage the next generation all over the world, we need to make sure we have hybrid type opportunities.
That's a really great point, because cancer is a global issue. Not only should the research be done, but there are over 10 million people a year die across the globe of cancer, and so it really is a global issue. We collaborate a lot. I think it's all hands on deck, but there's also been some challenges politically and others with different countries. I know you were a part of an ACR initiative to look at that and to try to make sure that we could continue to harmonize across the world with our cancer research. What are your thoughts about that?
Yeah, no, and one of my leadership roles right now is, the chairman of the international affairs, and thank you, Patrick, for helping with some of this. But we have groups who have experience in Africa, in Asia, in South America, in Europe. As we all know, it's complicated because it's not one country on each of those continents. There are many different countries with different cultures, with different amounts of funding, with different opportunities. And so, for instance, Africa, it's really hard. Like right now, what we're trying to do for Africa is just even find ways to get them sources of pathology reagents so that they can do pathologic analysis that we take for granted here. So whereas, in China, they're very sophisticated. So what we're trying to do is make sure there's good, improved exchange of information and trying to bypass the language barrier more than anything else, right? So I think, we have to first identify culturally and also politically. Politics comes into it with different governments, how you can even bring a conference to another country, as well as the funding available for these different countries. So one of the tacks we're taking now is more educational programs that could be virtual, to try to educate more people across the world and identifying what each group would want to see from an educational process. So again, maybe in China, they want to learn about the latest new technologies that are being developed, whereas in some African countries, they may want to learn about technologies that are already developed that they don't have good access to, or how to do a clinical trial. They don't do a lot of clinical trials there. How would you design your best clinical trial? So I think we're trying to gear educational programs to the different countries and regions. So that's one. We're trying to get materials when people don't have the materials for just taking care of cancer patients. And then we're trying to make connections and funding mechanisms. We have some funding mechanisms for all of the different countries, but in particular, believe it or not, there's a funding mechanism that is shared with the NIH and with the World Health Organization to fund some research, some researchers in Africa. A lot to be done.
Thanks for your work internationally, though. Liz, you've been such a leader internationally in thinking about these issues and making sure that, there's a lot of politics and rhetoric going around these days, but the bottom line is people across the globe die of cancer, and we all have to solve it together. And you've been instrumental in emphasizing that point and trying to make it possible for everybody across the world to collaborate, along with your role in the ACR and others. So we appreciate that a lot. Tell me, you've been in Baltimore for a number of years now. What if someone's visiting Baltimore, what are your recommendations?
That's great. Great question. So, of course, you have to eat crabs. Crabs are number one. And of course, we have a really great aquarium, so that's for sure. But I don't know, I just love Baltimore. There's so many neighborhoods people don't realize, but we have so many different neighborhoods that each have their own flavor. We have lots of immigrants from different areas of the world, and they give those neighborhoods a flavor. So I would recommend just walking around the city and just seeing how wonderful it is. We have some beautiful parks. It's really a lovely place to be. I've loved living in Baltimore. I mean, it's a city like every other city, so it does have its challenges, but it's people are very welcoming, and there's a lot of beauty and a lot of culture.
Yeah, I agree. I think it's a gem of a city and underappreciated by many, I think. And, having been there and lived there, met my wife there, I have a true place in my heart for Baltimore. So, Liz, any other topics you'd like to bring up today?
So, one thing I was thinking about in preparing for this was just kind of taking the audience back to, the early 1990s when SITC first started. And you know where I'm going with this. So just to give people a historical sense of how important SITC was, but also what our field looked like. So that's when people like Carl June and Steve Rosenberg were young, physician scientists thinking about the immune system and cancer. And, I remember they were both doing different forms of T-cell therapy. I don't think we were calling it CAR T-cells in those days, but genetically modifying cells, genetically modifying tumor cells as vaccines. I mean, there was all this happening, and SITC was really the place where we got together to discuss it, right? It brought us together because nobody else thought immunotherapy was going to have an impact in cancer. And it was just such an incredible time, but it was a small group. And, we didn't have pharmaceutical companies coming or, nobody thought this was going to be anything. So it's just us scientists, and all over the country coming together, some people from Europe maybe, but very small group. And now you take a look at this meeting every year, and it's huge and it's alive, and it's young people learning from now, the people who are much older, Carl June and Steve Rosenberg, and you and I are even in that older group now, and they're coming to learn from us. And there's just so much energy in the pharmaceutical companies and the biotech companies, and it's just so exciting. And we've just really hit the low-hanging fruit in our field. So I want young people to realize they've got to come in and join us. It's a great time, and there's so much more to do. We've really just begun, and it's already so alive, So it's such an exciting time to be in this field, and I just hope we can really encourage more people, to come and bring, innovation and work with all of us. So anyway, I just wanted to add that because I was really thinking a lot about, the old days. It was fun, but now it's so much more fun.
Absolutely. I remember being in a little meeting with you, and I think it was Asheville, and then we went to Nashville for the SITC meeting, and it was just these little tiny meetings. We would go, just a few of us going around, and now it's so exciting. And in a way, I envy the people just starting in the field now, because when we were there, we didn't know anything. We barely knew what T cells recognized or what could be recognized.
Exactly.
We didn't know what the antigens were or anything. So it's envious of these young people coming in now and what the potential is. We already can cure some cancers with immunotherapy, but the future is just going to be incredible, where it's going to, in combination with other treatments, cancer's going to be something of the past. I really do believe we can get there.
I'm with you. I totally agree with you.
Yeah. Well, Liz, again, thank you so much. Really honored to have the chat with you today. You've been so influential and so helpful to so many careers, and we really wanted to highlight that. So thanks so much.
Thank you, Patrick. Appreciate it.